Okay, well, good evening, everyone. And this is Barbara Jessing and
Joanna Halver.
And we're here at CSI in Omaha, Nebraska to start the webinar tonight. And our topic is child-parent psychotherapy and parent-child interaction therapy, when to refer. So it's a little ghostly. We know you're out there. We can't exactly see you or hear you. We hope that you will type in a question, or if there's any audio or any kind of problems, if you'll let us know, we'll try. So why don't we go ahead? Let me just tell you a little bit about our experience with these practices. For about the last 5 years, as part of a federal SAMHSA grant, we've had a child-parent psychotherapy learning collaborative across Nebraska, and we have trained, we're in our second cohort of therapists learning the child-parent psychotherapy model. We did our consultation and training with Joy Osofsky during the grant, and in the process of that grant, 4 of us here in Nebraska were enabled to be trainers in child-parent psychotherapy. So that's the practice that I'm here to talk a little bit about. And I'm going to ask Joanna if she'll tell a little bit about her experience with PCIT.
So let's see, I was trained in PCIT in 2012 by Beth Troutman. So shout out to Beth Troutman, my trainer. And there are several cohorts that have been trained in PCIT here. And most of the people here in Nebraska and Iowa have been trained by Beth Troutman, and then Kelly Schlegel also has been doing some trainings over in Iowa in PCIT.
Okay, I'm just going to figure out the slides here. So these, I think what's notable about these two practices, they both are evidence-based practices. They address the mental health needs of young children, birth to 5 in the case of CPP, and from 2 to about 7 for PCIT. So these are the questions that we put this presentation together to answer. For one thing, Medicaid in Nebraska in about the last 2 years has approved the utilization of CPP and PCIT for young children. Prior to this time, they were quite guarded or cautious about authorizing treatment for very young children. But because of the strength of evidence for these two practices, they did determine it was appropriate to pay for this treatment using medical necessity criteria for young children. So as these practices get more circulation, we find that people have a lot of questions. When should I refer to what kind of practice? What kind of questions should I ask a provider? We're going to talk tonight a little bit about good referral questions. How can I match my referral question to the right practitioner or referral source, and how can I find a provider? So this is, we know many of you in our audience are familiar with one or both of these practices, but we really want to do this more as an informed consumer. Lots of the people who refer to these practices may be judges or case managers or other people who may not be experts in the practice, and oftentimes are trying to determine which way to go. So the way we want to think about this is you need to be a good consumer. Just as we don't have all the expertise that we need for our own medical care, we have to be able still to ask a medical practitioner some intelligent questions, and those practitioners should be listening and sensitive to that. So we hope the intent of this webinar is to help us be better informed consumers who will be comfortable asking early childhood mental health professionals about these practices and about particular kids and referrals that they have. So that's what we have in mind. So we're going to just do a quick little overview for those of you that would like the comparison. What is CPP? What is PCIT? Then we want to spend a little time talking about what is a comprehensive trauma assessment for a young child, because often that's what it's going to take to know which of these practices is particularly appropriate, and what kind of questions should I ask of a prospective provider. So let me just give a little background on child-parent psychotherapy. This is an intervention that's designed actually for children birth through 5 with their caregivers. And it was designed for children who have experienced some sort of early trauma exposure. It could be child maltreatment, Much of the research that's been done on CPP has been with children exposed to domestic violence, sometimes traumatic loss of a caregiver, but also kids who experience disruptions of caregiving, who maybe move from home to foster home or one foster home to another. Also children who experience injuries, accidents, or painful medical procedures. These are highly stressful events that can disrupt the development of the young child, disrupt their capacity, the evolving attachment. And so this is an intervention that can be brought to bear on children who have had these experiences, and as a result, we're seeing some mental health, attachment, or behavioral problems, or we even like to think of it as their social and emotional development has been derailed by these events. So some of the diagnoses that may be appropriate for child-parent psychotherapy are PTSD, which can be manifest in young children. There are a range of anxiety disorders. Young children can exhibit depression. At the mildest end, we have kids with adjustment reactions to these stressful circumstances, and with complications, we can see attachment-related diagnoses with young children as well. So this is the population that CPP is intended to address. So a little bit about what the sessions look like. The child and caregiver are the focus of the intervention. It's a dyadic therapy. The focus is on the parent-child relationship, with the belief that that is what is going to best help the child resolve symptoms. And so the therapist role is in attunement to the parent-child relationship and to healing and strengthening that relationship. So we have just a little short video. This is a volunteer mom. You might even recognize her. Some of you will know her. And you will see her with her 3-year-old son. I'm going to turn off the mic for a minute and start the video.
Okay. Okay, let's put these in here.
That's the go.
Yeah, can you grab Elmo and Piglet over there?
That's a bunny, and this is a frog.
Is that a frog or is that Elmo from Sesame Street?
That's for Sesame Street.
Okay.
And
Let's check the bubbles. Ooh, looky here.
that's kind of like the bug juice.
It looks like bug juice. It does. It looks like strawberry banana bug juice.
Yummy.
Ooh, smell.
It smells strawberries.
It does smell like strawberries, doesn't it?
I'm going to take them around. I'm going to chase them
You're
around.
going to taste the bubbles? Okay, ready, set,
Gotcha.
go! Want some more?
Yeah.
Okay, ready? Ready? Whoops! I didn't get very many good ones that time.
I don't pop.
It didn't work. Alright, you want to try one?
Yeah.
Okay. Hachoo! Hacha! Hacha! Woohoo! Got him. My turn or your turn?
My
Your turn to pop or blow?
turn. No, my turn to pop.
Okay. Ready?
Yeah.
Set. Go! What behind you? Oh, got them all. Ready?
Yeah.
Set.
Go! Hey, this one. This one. It's falling on my knee.
You think it's on your knee? See if we can get one.
Hey, can I hold it?
Sure. Okay, remember we have to be very careful with bubbles. Not to spill. Achoo, 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 achoo. Pop. let me see. Pop, 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 pop. Pop, 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 pop. Ow! I can't get them all. Oops. Pop, can you get some? They're flying. Look, Max is flying. Ha. See if we can get him to fly.
Come on.
Come on. Okay, let me blow him up high. High in the air.
I'm flying. Josh.
Whoop.
Oopsies.
Here, let's put that here, and you can dip it and then blow, okay? Get it, run!
Come on. Look,
Little fella, come here, little fella. Hello?
let's try that a little further.
Okay. Okay.
Okay, let's see, I'm trying to get back to the PowerPoint here. Oh, there we go. So just a few comments. As I mentioned, this is a volunteer mom. This is a mom and child that are pretty well attuned with each other. But one of the applications of child-parent psychotherapy is when children and parents sometimes together have been witnesses to domestic violence. So I'm just thinking, here's a mom who's pretty comfortable with a very active physical boy who wants to stomp and chop the bubbles. And with families struggling with domestic violence, we often see a mom kind of overreacting or being triggered by a child's aggressive behavior. So as we get to know the parent and child, as we observe the relationship, we're watching for those kinds of things so that we can then speak with the parent about how this interacts with their own history. It's one of the unique things about CPP is that it kind of, it addresses the parent's trauma history as well as anything that may have happened to the child. Those observation sessions also give us time to see how attuned parent and child are together. Can they take turns? One of the things we have the child do, or have the parent do, is instruct the child to clean up. So these first few sessions give us an idea of what's the quality of the relationship, how has it been affected by the shared or separate trauma history, and what are some of the points that we want to focus on as we get to treatment. So the idea behind CPP is support and strengthen the parent-child relationship, that's our best vehicle of getting to help the child's mental health. It's to help the child resolve a shared trauma by creating a joint narrative, and with these young children, that narrative emerges in play. In the children's play, we see their themes and dilemmas, and we help the parent to see that as well. It can also help us identify, as I mentioned, some of those triggers. If a child's aggressive or angry behavior is paralyzing to the mom, then we can help her become more aware of that and to be able to regulate her feelings and behavior in relation to that child. So treatment intensity and duration. CPP sessions are typically held weekly, although that interval may increase between sessions as the family stabilizes. A typical course of CPP, according to Alicia Lieberman and the developers at UCSF, can be up to a year. In our Safe Start grant, where we applied CPP with our drug court families, we found a sort of an average duration of 16 to 20 weeks, a little shorter than that. And the variable we found with the duration of treatment was really the level of functioning of the parent. Depending on how well they were doing, that shorter length of stay might be effective, and sometimes it was longer. So just a little bit about necessary conditions. CPP is an intervention that has to be done with the child and a stable caregiver. We hope that's their permanent parent, their biological parent, or the parent with whom they're going to have permanency. the parent needs to have some minimal capacity. Lots of the families we worked with in drug court were just in the early stages of treatment. And even then, if they had some motivation and minimal capacity to be present, we would attempt to start CPP. But it really does rest on the permanency goal for the child. We have to have a reasonable idea that this is the intended partner for that child to help them attain permanency. However, the CPP is for the child, and if their bio parent can't participate, is there another trusted person, a foster parent, a relative caregiver, who can partner with the child in that treatment. The contraindications, the primary one is when there is severe ongoing family violence. We cannot convey a message of you are safe in this relationship to this child if they are going home every day to an environment that is not safe. Serious impairment of the parent to the degree that they can't participate, they can't be dependable, can't focus on the needs of the child. And occasionally we have children with such a strong reaction of distress that we can't mitigate with the parent, and that would be a contraindication. So theoretical foundations of CPP, just real briefly, it comes out of attachment theory. The origins of CPP are in psychodynamic parent-child therapies, and it also integrates trauma theory. And this is just a little series of diagrams. These are from Chandra Ghosh Ippen at the University of California at San Francisco. But as child and parent enter treatment, each has that cloud of trauma hanging over them. They've experienced it, they've each experienced it, but it is almost like a separate experience. What happens during the treatment process is that we are able, through the mechanism of play, of creating a narrative that's shared, to find a way to contain and minimize the disruptive effects of that trauma. You see it being contained in the little box there. Part of the goal of CPP is to restore the protective shield so that the child isn't facing those traumas alone, but the parent functions as they should as a protective figure in the child's life and creates a barrier to that threat. For the parents, we hope that CPP helps them understand the connection between that traumatic experience that each has had and current emotions and behavior. Mom needs to become aware, for example, if she's triggered by angry males, that's something that could interfere in her relationship with her son and might even have something to do with the behavior problems that he presents to her. And post-treatment is back on track. The trauma is contained, it's manageable, and we see the parent-child relationship restored. So that's just a really quick overview. I'm going to ask Joanna now if she'll talk a little bit about the premises of parent-child interaction therapy.
Okay. So PCIT was developed by Sheila Iberg, and it's an evidence-based practice for kiddos age 2 to 7. And there is an older child protocol that some providers use that you can use with children up to age 12. And it's meant for kiddos who have disruptive behaviors. That includes aggression, destructive behaviors, as well as severe tantrums. And a very common presenting problem for kiddos who are referred for PCIT are those big tantrums. And also, you know, some kids may have a diagnosis of oppositional defiant disorder, disruptive behavior disorder, ADHD, and so the main idea behind PCIT is for those kiddos with those really big disruptive behavior disorders. So it looks like sessions, again, with the child and the caregiver are both involved in the sessions. And so there are 2 phases to the therapy. The parent and child are in the therapy room, and in most models, the therapist is actually behind a one-way mirror. And the parent wears a little bug in the ear device, and so the therapist is able to communicate with the parent and able to coach the parent and the dyad during real-time interactions through the one-way mirror. And the 2 phases for PCIT are child-directed interaction, and in that phase is really where the therapist is focused, their attention is focused on increasing those positive interactions between the caregiver and child. and the parent is taught a specific set of skills to help them with that, and we'll talk about those skills in a minute. And then the second phase is called PDI, or parent-directed interaction. And in that phase, the therapist's attention is focused on helping the caregiver use effective commands and being consistent with discipline. So we're going to show a little video. So some of you may recognize this therapist in the video. This is a news story that was on the Omaha News a couple of years ago. Lisa DeZuris is the therapist. At this time she was at Lutheran, and she is a PCIT trained provider. And this is a little news story about PCIT. It gives a really nice overview of what PCIT looks like. And Lisa is now at Nebraska Children's Home doing PCIT and CPP work in their Healthy Families America program.
You know, kids really do pick up on the littlest things.
So when they hear adults yelling and see bad behavior,
You know, kids really do pick up on the littlest things.
So when they hear adults yelling and see bad behavior, you can be sure they'll act the same way.
New tonight, a learning lesson for parents hoping to change they interact with their children. Here's KATV News Watch 7's Julie Cornell.
She's a mom
There it is.
who's learning how to nurture her children. Just months ago, Patty Serrett's little girls were just
Pick up on the littlest things.
So when they hear adults yelling and see bad behavior, you can be sure they'll act the same way.
New tonight, a learning lesson for parents hoping to change the way they interact with their Pick up on the littlest things.
So when they hear adults yelling,
Littlest things.
speak how to nurture.
For this,
Lisa DeZuris is a child therapist and parenting coach at Lutheran Family Services. She remembers telling Patty,
I can guarantee if we do this treatment and if you follow through, things will be better.
the two invited us
Come in and ask for this.
Lisa DeZuris is a child therapist and parenting coach at Lutheran Family Services. She remembers telling Patty,
I can guarantee if we do this treatment and if you follow through, things will be better.
the two invited us into this unique treatment. We're not showing Veronica's face because her therapy still continues.
It goes real fast.
There's a two-way mirror,
The two-way mirror also then gives us the ability to observe.
and the mom and therapist both wear an earpiece and mic things out.
Well, sorry about that. It looks like that video is just pretty choppy, so we're going to just go back to the PowerPoint. But could you say a little bit, Joanna, about the parent participation and just...
Yes. So we, oh, wait till we get back to the slide. If you want to go forward,
Oh,
the pictures, yeah. So we actually weren't sure if the video was going to work, so I did have to put a few pictures in here. So the parent and child are in the room, and so during the first phase, during CDI, the parent is taught a set of skills called the PRIDE skills. And so the acronym stands for praise, reflection, imitate, describe, and enjoy. So really we're teaching the parent how to use skills that play therapists use to join with kiddos to build a positive relationship with their child. And they definitely praise the positive. We have them save questions and avoid negatives. The number one sort of rule for CDI for parents is to follow the child's lead. And so they're really working to help the child tune into the behaviors they like by praising the behaviors they like and ignoring the behaviors that they don't, those disruptive behaviors. Reflections are saying what they say, so it's parroting back what the child is saying. It helps the child know that the parent is paying attention, the parent is tuned in to what the child is doing. We teach the parent to imitate the child, so if the child flies the plane through the air and makes plane noises, the parent does the same thing. It's really a way for that parent to follow that child's lead. We teach them to describe the behaviors, so parents say things like, "You're driving the car down the track," and "You are pulling the train into the station." And it really helps the child know that the parent is tuned in to what they're doing. We also have them describe things that they like, so things like, "You're playing with the train so nicely." And then the last skill is really just to enjoy, and that's really just to relax, have fun, and enjoy time with the child. And the parent is being coached during those live interactions. The therapist is pointing out when the parent is using those skills and helping to reinforce the parent's use of those skills. Okay, if you want to go back a slide. Let's see. So the way that CDI works is it encourages those pro-social behaviors as well for those kiddos, and it discourages all those negative behaviors. It increases those positive interactions and actually restructures the parent-child relationship. And then the caregiver and child are given homework assignments to practice 5 minutes of daily CDI and pride skill use play at home as homework. So they're getting a lot of practice during sessions and or between sessions, and they're coming back and reporting to the therapist how that daily CDI interaction went at home. And what we know from research is that PCIT actually changes the parent's perceptions of the child by teaching them, restructuring that relationship. So.
PDI?
So in PDI, this is the second phase. So after the parent has reached what we call mastery, so there's a set of mastery criteria that the parent has to meet, which is basically a high level of the pride skill use during sessions. And so the therapist is coding the parent each session to determine their level of skill use of the pride skills. And there's a predetermined set of mastery criteria that the parent is very aware of that they're working towards. So once they've met mastery of those CDI skills, then they move on to the PDI skills. And this is the parent-directed interaction portion of the model. And I firmly believe that one of the reasons why PCIT works so well is because of the CDI portion. So because of that relationship portion, building those positive interactions, that is why the child is able to accept parents' redirection in the second phase. So during PDI, the therapist is coaching the caregiver to implement consistent use of direct commands and then appropriate follow-through. So if the child follows the direct command, then the parent is coached to praise that child, and if the child does not follow the command, then the parent is coached in a timeout procedure. And so by teaching them to deliver those effective commands, it increases that child's compliance. And then they are assigned progressive homework assignments at home as they learn those PDI skills. They continue their daily CDI, positive interaction skills at home, and then they start adding in commands, adding in timeouts, things like that during those playtimes. So it progressively works towards them implementing this at home. So intensity and duration, so they're typically held, sessions are typically held weekly, and then as the parents reach graduation criteria and near towards discharge, then we'll typically increase intervals. So there's also a predetermined set of graduation criteria, and so progression in PCIT is based on the parents achieving mastery of each of the skills. So they have to achieve mastery of the PDI skills, mastery of the CDI skills, as well as at the time of discharge, in order for them to meet graduation criteria, parents need to report a confidence in managing their kiddos' disruptive behaviors. And then there's an assessment tool that we'll talk about here in a minute called the ECBI. And so the ECBE score is recorded every session, and when that ECBE score is in the graduation range, that's the final graduation criteria. PCIT is very assessment driven, and you track that ECBE score over time. You're tracking the parents' mastery. They're getting real life feedback in the moment of how they're doing in progression of PCIT. So some of the necessary conditions, you definitely have to have a stable caregiver for the child and someone to participate with the child, and they have to have at least minimal capacity to attend regularly. We talk a lot about and stress with parents how important it is to attend sessions regularly, to practice during sessions. The more that they practice, the more regularly they attend, the quicker they're going to progress through the skills and learn the skills. We want some sort of reasonable clarity about permanency goals, but this does not mean that if a child is in foster care, they can't participate in PCIT. We have had lots of success with foster parents coming to PCIT and also the biological parents coming to PCIT. So for the same kiddo, both are coming, they're both learning the skills, the child is getting that consistency across both settings, which is really nice. We had a case where there was a grandma, an uncle, and a mom all living in the home, all parenting a kiddo. All three of them came to PCIT consistently. All three of them met mastery criteria, and the family graduated, and the kiddo's doing great. So, you know, the more caregivers that can participate, the better, and the focus is definitely on the child. We also have found that sometimes kiddos with these really significant disruptive behaviors in foster care are at high risk for disrupting that placement. So it can be really, really helpful to help these foster parents learn these skills in order to prevent that placement disruption. Some contraindications. So if there's severe marital discord between parents, PCIT can be a challenge because we want both parents to be able to support each other and be reasonably on the same page. Definitely serious mental health and substance abuse impairment of the caregiver if they're not dependable, if they can't focus on the child's needs. That makes PCIT difficult. But again, we can start with the foster parent and add that biological parent as needed when they're ready, when they've done their treatment. If there's parents who are known perpetrators of sexual abuse, they would be inappropriate. And then severe ADHD without medication consultation. So real quick, these are just some theoretical foundations of PCIT. PCIT comes out of social learning theory, attachment theory, and play therapy.
Okay, so we're going to shift a little bit now and talk about some of the similarities and differences between CPP and PCIT. First of all, if you could keep all of that in mind that you just heard, you might have heard a few common themes. But these are both dyadic therapies. They focus on the active participation of the caregiver with the child, so that's a similarity. Although CPP addresses attachment more explicitly, it's really a necessary element in both interventions. We're addressing it in different ways, but it's that relationship that needs to be strengthened and helped in order for the child to have their symptoms resolved. And probably most prominently, developmental guidance, coaching and helping in the guidance and discipline of the child is part of both models. So on this next slide, and you're going to get copies of these. I know Charlie has said that she will send them out, so you'll have the slides to reference. First of all, the age span is a little different. CPP has been utilized with infants through age 5. And Joanna, do you want to talk about the age range?
Yes, and so it's 2 to 7, and again, I did mention before, there is an older child protocol with some modifications for PCIT so that it can be offered to kids up through 12, and Medicaid, Magellan here in Nebraska, has approved PCIT for kids up through 12 with that modified older child protocol.
Okay, and you saw the therapist is typically in the room. That wasn't the case in the little video we saw, but the parent, child, and therapist are in the room together. And the structure of CPP sessions is a bit more fluid and flexible.
And then with PCIT, the therapist is coaching usually from outside of the room. Now, some providers that don't have access to a one-way mirror, there is in-room coaching options available. So if you don't have access to a one-way mirror, you can coach in the room as well. It just looks a little different, but typically the therapist is outside the room coaching through a one-way mirror. The parent wears a bug in the ear. The therapist has a microphone to communicate with that parent.
Okay. So we mentioned that developmental guidance is a common theme. In CPP, it's one of several different modalities that may be used at different times, helping the parent to manage the child's behavior, to understand it, to respond to it differently, and to be aware of what it triggers in them. And then how does that look in PCIT?
And in PCIT, it is one of the primary modalities, and then as well as also strengthening that relationship, restructuring that relationship.
So I think it would be fair to say that both models, if you are in the business of young children, you are dealing with behavioral issues. And for CPP, that's probably in the milder to moderate range.
Mm-hmm. And PCIT is appropriate. It can be appropriate for kiddos with kind of that moderate to very severe. So we have worked with some kiddos with very, very severely aggressive behaviors, little 2-year-olds with very aggressive behaviors, very destructive behaviors, you know, spitting, kicking, hitting, swearing, so really, really big behaviors for a little one.
Okay. And in regard to trauma focus, CPP actively addresses issues of trauma as those are revealed in the child's play and revealed in the parent-child relationship.
And then PCIT doesn't necessarily directly address trauma, true PCIT, but it definitely stabilizes the family and works on helping with those big behaviors, those externalizing behaviors of trauma in order to proceed.
Okay, so we're going to talk a little bit more about how that decision is made. So it's good to know about these therapeutic practices, but for those that are outside the mental health delivery system, you don't have to be an expert and try to guess in advance. I think it helps to view children's needs through that trauma-informed lens and to look for a practitioner that understands the needs of very young children. So a good, reliable, comprehensive mental health evaluation is going to be the best way to determine which of these practices, or maybe there's another practice, is best for this child. So lots of times we see, like we even have judges ordering one or the other practice, which is well-intentioned, but really what we'd rather see is a quality early childhood evaluation and then the recommendations of that practitioner about what would be the best approach. It's important that parents are included in either of these therapies, but also collateral information and parent history and engaging the parent as early as possible is valuable too. So we want to just talk a little bit about a quality early childhood mental health evaluation. What does it look like? What are the elements that are going to be there? And then in a bit we'll talk about some of the questions that you may want to ask. We don't always know. What a child presents tells us only a little bit. As we get to know them better, as we get to know their parents, as we get their history, other events may emerge. So assessing for a wide range of experiences is important, because it may not be the one we know about, or there may be more than we know about, I should say. So assess for a wide range of trauma exposure using clinical interviews and standardized measures, and we'll talk a little bit about what some of those are. It's important that we consider co-occurring conditions such as depression, anxiety, and inattention. A good early childhood mental health evaluation has some systematic means of observing parent-child interaction and relationship. That's the case certainly in PCIT. In CPP, we start by observing and looking for patterns in the parent-child relationship, identifying what works, where are the gaps, where are the triggers, so that we can help to design an appropriate intervention. A good early childhood mental health evaluation is also going to have a developmental component. A screening for developmental milestones such as the ASQ, because one thing we know is that toxic stress and trauma can impede a child's development, and we're often seeing kids who aren't on track with language and social and emotional milestones, even sometimes health and physical. So We typically include a developmental screening, and also we check to make sure that if needed, that child gets an early development network evaluation, which is offered through the public schools.
And often, too, we're making recommendations, if kiddos are having delays, things like getting them into a high-quality child care center and some of those opportunities to help increase that development, increase their opportunities to interact with peers. So absolutely, that's a huge component for both, to screen that and make sure that kids are developmentally on track.
Yeah. And it's important to have context for these relationships. So for that early childhood mental health practitioner, the more they know about the child and family history, the better. They need collateral information from other professionals. This is not the kind of therapy that you can do, and some have tried, to send a child in a cab on their own. It's not like these problems are going to only show up in the interview. It's getting the full context around that, understanding what questions, what reasons for referral, and knowing what's this child's life been like so far.
And one other thing to say, too, about the collateral and development, we have found that sometimes when we have talked with biological parents, if they have not spent a lot of time with the kiddos, or if the kiddo has been in care for a large chunk of their life, it's so important to talk with those foster parents and those direct caregivers who are working with that kiddo and that kiddo is living with, to get their input on development as well. So.
Okay, an early childhood mental health evaluation will likely include some standardized measures, developmental screenings being one. Do you want to talk a little bit about the IBERG, and then we'll have an example to show
Yes.
too?
Yep. So I mentioned earlier the IBERG, so that it's the ECBI, the IBERG Child Behavior Inventory, and most providers who have been trained in PCIT are using this pretty regularly. We administer it at every session. It's a quick sort of back and front page, just two-page little inventory. And once parents have done it a couple times, they can kind of breeze right through it. And so it measures two things. It measures the intensity of the kiddo's behavior. So there's a whole bunch of different behaviors listed, and parents are asked to sort of rate how intense is that behavior this week. And then there's also is this behavior a problem for you? So it gives you an idea of how much of a problem are the kiddo's behaviors for the parent. So it sort of measures both of those, and then we're going to go ahead and I'll have Barb go forward. So when we're doing this at every session, then we are able to start to track that child's intensity. So you can see this is sort of a chart of an ECBI intensity score, and at the bottom of the chart you can see the different sessions as the child progresses. And then the ECBI score, as it sort of kind of starts high and then dips down a bit, goes high again, and then really just starts to go lower, lower. And this is a really powerful tool to show to families when we chart this every week, and we can take this into session and we can show parents, look, the intensity is going down, and they have a nice visual to see that. Sometimes they don't notice those subtle things, and this really helps them really see that their kiddo is getting better and those behaviors are getting less intense over time. The more they use the skills, the more they participate in PCIT.
Do you want to comment on why it might get worse?
Yes, and so we have found actually that it sometimes gets worse around when we start PDI, and there's actually, this is a real kiddo, this example that I worked with, and so he very much spiked as we went into PDI, and so sometimes as parents are sort of taking that initiative, or sort of taking the directive approach with the kiddo. They've gone from CDI, where they're very, there's a lot of relationship building, a lot of positivity, and now they're giving commands, and they're basically putting the kiddo in timeout. So sometimes that will spike. We'll see that intensity spike a bit as the child sort of reacts to that, and then it starts to level off and go back down again. So.
Okay. And we'll go back and just talk about a couple of other instruments. These are just a few examples that are commonly used, but there may be others. The Child Behavior Checklist has an early childhood and a school-age version, and that gives a pretty good profile of a child's symptoms in terms of, are they in that normal range? Are they at the clinical range where they might correlate with a diagnosis? So it's a good way of sort of covering all the potential domains of a child's functioning and getting a profile of how they compare to other kids their age.
And one thing I really like about the CBCL too, that it makes it very easy to see kind of those internalizing behaviors as well as externalizing behaviors. And so a lot of times with kiddos, those externalizing behaviors get a lot of attention from parents, but they don't necessarily always see those internalizing behaviors. So it does a nice job of grouping those two and giving you a real clear picture of where that kiddo falls.
And we just mentioned a couple of trauma screening measures. One is the TESI, or the Traumatic Event Screening Inventory, which is a parent report. And then the Trauma Symptom Checklist for Young Children is another well-established research instrument for understanding the severity of a child's trauma symptoms and to help identify the diagnosis of PTSD. So we're going to walk through a decision tree, and again, I know you're going to get this in print tomorrow, so we apologize for the kind of small print here, but we're going to kind of talk through what kind of questions might lead us to one or the other practice, supported by clinical judgment, but this gives us some idea.
And this decision tree is put out by UC Davis PCIT program, so it's on their website as well, on the UC Davis website.
Yeah. Okay, so for starting with age, if the child is in the age range of 2 to 7, then if they're not, we're going to look at a practice that is appropriate for older or younger children. CPP, for example, would serve the child younger than 2. There's a model called trauma-focused cognitive behavioral therapy, which has roots in very similar approaches, which is appropriate for children who are older than 7 as well. But if that's a child in the 2 to 7, then the next question we're going to ask is, what's the intensity of their externalizing behavior? And that's where you want to talk about how the ECBE might be informative there.
Yeah, so the ECBE has a sort of a set threshold of where that behavior falls in the clinical range. And so if a kiddo's externalizing behaviors fall in that clinical range, then PCIT may be an appropriate model, because it's really going to work on addressing those externalizing behaviors and making sure that everybody, that those behaviors get better for that kiddo.
Okay, so if externalizing behaviors are pretty intense, we're going to go forward here. If not, we're going to look at other models that might better address the child's internalizing behaviors. But we've still got severe behavior here. Then the next question is, are there trauma symptoms? So depending on the severity here of trauma symptoms, if no, do you want to talk about that little branch toward PCIT?
Sure, then definitely, PCIT would be appropriate. You'd be addressing all those externalizing behaviors, and if there's no trauma present, then, yeah.
Okay, then this next box, what if the placement is stability is threatened by the child's behavior, even though there are trauma symptoms, but the combination of trauma and severe behavior threatens the placement?
Yes, and that's where we found PCIT to be really helpful, because it really does help foster parents to get some real skills and work with that kiddo on those externalizing behaviors and get some understanding of where those externalizing behaviors may be coming from and how to respond to them in appropriate ways, as well as how to really restructure and build that relationship with the foster parent.
Okay. So shall we look at the next factors?
Yes.
These are child and family factors, and then there's a similar tree for parent factors. Is the caregiver scared or scary? That is, are they a victim as of domestic violence, or are they potentially the scary figure to the child of physical abuse?
And PCIT can be helpful in that way, because it really is going to help that parent learn new ways to interact with that kiddo. It's going to help them increase those positive discipline skills and stop all of the, maybe punitive things they may be doing, or shaming they may be doing, or criticism they may be doing. It's really going to restructure that parent and help them learn how to use positive discipline instead of negative discipline techniques.
Okay. Does the clinical observation indicate the child is displaying disruptive behaviors? And again, we'd have a question of severity there. With more severe, yes. With less severe, we would consider CPP. Can the caregiver distinguish between distress and disobedience? If yes, we might look at PCIT.
And if no, then that may not be appropriate.
Right. Does noticing
The
positive behavior alone create a shift in the relationship? If yes, we proceed toward PCIT. If no, that would be a locus of attention in CPP. So maybe more than you want to know, but I think the point we want to make is that a comprehensive assessment with somebody skilled with young children and with these appropriate measures and with some direct observation is going to be the best informed decision about what practice would really be a good fit for this child and family. Okay, so why don't we go on? I think we want to do one case example. I think we've got time for it. It's about 8:30. We're going to leave some time for questions, which I know you're going to have to type in. So you could be thinking about those now, and in a few minutes we'll get to them. But this was a case that came up in our consultation recently where one of our participating therapists was so excited because she got her first CPP case, and this is what that case was about. This was a 4-year-old and came to their community agency with his mother, and the mother reported that the child was aggressive toward other children in the home. He didn't like being told no. He had some pretty big tantrums, and she had really just developed a pattern of caving into that. She said, I think he has ADHD. Can you give him some medicine? He doesn't listen to me, and it's bad enough that it's hard for me to control him anymore. So this little 4-year-old was pretty out of control, and mom wasn't able to exert much in the way of appropriate direction. So talking about referral question, we'll get back to that, but this was a child that was under DHS supervision, and they had asked the mom to get therapy. He had recently been placed back with his mom, and they wanted that placement to be successful. HHS was concerned about his diagnosis and should he be on medication, and what kind of therapy would be the most effective for him. So those were some of the referral questions coming from the case manager. During the initial assessment, the therapist immediately, I mean, it was more than a little noticeable, the child threw play materials around the office. He tried to escape several times to get to the street. He actually broke a door. And in this very aggressive outburst, mom was pretty static. She didn't do much to intervene, didn't know what to do, didn't seem real motivated, wasn't particularly concerned. And it was difficult to complete the interview and arrive at a diagnosis, but I think your wheels are probably turning as ours are. And let's take a look at the history first, because I think this is a great example of without knowing what's happened, we'd be slow to do that. But here's just a little bit of child history. His father had died before he was born. The other time there had been a protective service intervention is when he was 2, and it was a dirty house call. He was removed at age 2 years, removed for 1 week, and he was returned when the immediate crisis of the house was resolved, but it was noted in the history that his mother was yelling that she was just going to turn him over to his grandmother, which through an informal kinship arrangement they did. So from age birth to 2, he was with his mom. From 2 until 4, he was with his grandmother, and he had just a few months before this assessment been returned to his mother along with there is a 2-year-old brother in the home with mom. So he had some disrupted attachment. He was not real familiar with his mom. He was new to being back home and had clearly had a series of losses and disruptions. So we don't know too much about mom's history, but we learned that she had a mood disorder, certainly depression, probably postpartum depression, maybe bipolar depression, has lived in a series of abusive relationships, and probably has a drug problem. So thinking about the attachment disruption, I think the original referral was for CPP. The thought was, we've got a therapist now, they're trained in CPP, there's an attachment problem, so let's refer this child. So we have to look at that and make sense of what's happening now, what missing information do I need. For purposes of this discussion, we're going to focus on kind of formulation and intervention, but the question was, what's the best kind of therapy that's going to help this child? And certainly for the therapist newly trained in CPP, she was wondering if it was the most appropriate. So we had thought about brainstorming. It seems a little disconnected, so I think we'll just talk a little bit about what happened in this particular case. But I think if you could think back on that flow chart, we had a child with some pretty severe externalizing behaviors. He certainly had a trauma history. There was no question about the disruption and just the absence of attachment that was displayed with his mom's lack of confidence and her lack of skill. And so we would probably, had we had an IBERT score at that time, it would have been fairly high. I would guess a trauma symptom screening would have been significantly high. But the conclusion that was reached in this case is this is a little guy that could probably benefit from the structure of PCIT, and we could see if his mom could be energized and motivated to manage his behavior better, and that we would still be looking at how do we address the trauma. And one of the things we wanted to talk about is that many of our therapists that have been part of this CPP grant are also PCIT trained. And so that's the ideal. We aren't there in every community yet, but when we are, maybe it's that same person who can help stabilize the family with PCIT. Or even within our CPP therapy, we have sometimes used some of the PCIT interventions to help with some severe and aggressive behavior. In this case, the decision was made to proceed with PCIT and see how they did. So just a quick example. I think we're going to skip our other case and go to yeah. Okay, so going back to that question of informed consumer, which those of you that are referring kids for therapy, maybe not the providers of therapy or the experts in what kind of therapy, I think one thing that because of the Magellan process, what you can now ask a provider is, are you approved as a provider of PCIT or CPP by Nebraska Magellan? That's above and beyond being enrolled as a Medicaid provider. They have sort of a second level process for approving providers of PCIT and CPP. And what Magellan did in formulating their standards was to go to UCSF, and they went to the experts in PCIT and said, tell us what's the right route to training? What does it take to be a capable practitioner? What's the initial training like? What kind of training, supervision, and experience should a person have to be capable of delivering these practices? So when a therapist goes to Magellan and says, I'd like to be approved as a provider of CPP or PCIT, they're going to have to actually show their training certificates. They're going to have to show that they have done their consultations or are doing their consultations. They have a period of time with CPP, I think it's 18 months. I don't know if it's different with PCIT, but you have 18 months to complete those requirements. And in the process, while you're getting consultation and supervision, you do have to be fully licensed in order to apply. So if the practitioner you were thinking about has registered with Magellan as a provider, and that's the only condition in which they will pay for the therapy, then that is some indication that they've had the recommended type and amount of training.
And with PCIT, it's you have to have the advanced 40-hour, or I'm sorry, the basic 40-hour training as well as the advanced training. So it's a total of, I think, 60 hours of training. And then you have to have received supervision on 2 cases and have basically seen those cases to graduation criteria and graduated those cases successfully. And again, you have to submit certificates, submit all your evidence of all your training, and usually have your trainer sign off on your letter verifying you've had that experience. So, another good question to ask of a early childhood mental health therapist is what their experience and their training is working with traumatized young children. So really, you know, working with kiddos age 0 to 7 is sort of a unique niche, and so you want to make sure that if you are referring a kiddo that age to a therapist, they need to have some sort of specialized training or experience working with young children.
Okay, and another good question is just how do you incorporate attachment theories in your work? Again, if you work with this age group, you have to have some kind of lens or framework of understanding attachment, and it's a reasonable question to ask that they explain to you.
Another question, how do you make your services welcoming and inviting to parents and caregivers, as well as to kiddos? You know, in order to work with young kids, you need to be able to be inviting, and you need to have some special skills to work with those kids. So what sort of things do you do to make your services welcoming and inviting?
One just vast area of learning that we've had in the CPP Learning Collaborative is just remembering that most of the adults we work with have, and we do ask about their early history, their trauma exposure, we ask about their attachment experience. It helps us kind of understand what they have to work with. But it's just everything we know about working with children that have attachment disruptions and violence exposure, it gives us a way of understanding the parents almost in the very same framework, that these are also parents who have fragile connections with other people, who are not trustful, who have not had dependable caregivers around them. So these are often parents that are slow to engage, that are somewhat defended, and so we bring to bear all the skills of understanding attachment issues in children. We have to really apply those with the adults as well.
Also, I want to ask, what sorts of collateral information do you need to do a good evaluation? You want someone who's going to do their homework. You want someone who's going to not just meet with the kiddo, but is going to meet with the caregivers, and get all of that good collateral information. If there's a caseworker involved, get every report that they can get, because that collateral information and that history is so important to understand the context of that dyad's relationship.
Okay. We mentioned some standardized assessment tools before, and it's reasonable to ask what are those which are appropriate for your practice with young children.
You also want to ask what sorts of observations do they do of the dyad, of the child-caregiver interaction. If somebody is going to assess a young child for mental health needs and make recommendations, it's absolutely crucial that they are assessing that interaction and watching that child with their caregiver.
Okay. How many cases have you completed in these models? As I mentioned, the training standards in these practices and that Magellan has emulated in their criteria include case completion, but just like you want to know from your surgeon how many knees have you replaced, you want to ask how many cases and with what kind of results have you done.
It's reasonable to ask kind of what the therapist expects the length of treatment to be, and of course this might be a hard question to ask or answer, and they may not have a specific number of sessions, but just to get a general idea of sort of what's the length of treatment that's anticipated.
Yeah, and related to that, it should be anyway, is how do you measure progress? Treatment should proceed while progress is being made, and 2 questions: what do you do? How do you measure progress? The ECBI is an example. They aren't all quantifiable, but how do we know that kids are getting better? How do you assess that? And when they're not, what do you do when things get stuck? What are your resources when we aren't seeing progress?
And then another important question to ask is about the provider's supervision or consultation that they receive. When you're working with early childhood mental health, it is so important that that provider is getting some sort of supervision or consultation, preferably some sort of reflective supervision and consultation in order to do early childhood work. That's very important.
Okay, so one thing we thought would be helpful to talk a little bit about is referral questions. We make referrals for a reason, and the clearer we can be about the question that we hope will be answered by that referral, the more likely it will be answered. So the more specific you can be in making a referral for an early childhood mental health evaluation is just to tell as much as you can about what's the condition or problem in this child's life that's of concern. Oftentimes these referrals get made when many other things have been tried. So what's missing, what's unclear, what's confusing in this case? And if you could just picture when you eventually get that therapist's initial evaluation or their treatment summary, what answers are you going to be looking for in that evaluation? So the more specific your question can be about here's my dilemma, here's what I'd like to know about this family, the clearer you can be about that, the better, and the more likely you are to get a specific answer. Lots of mental health practitioners are perfectly willing to jump in and try to figure that out, but the clearer you can be at the beginning, the better. Any other comments on that, Joanna?
I don't think so.
Okay.
And so this is just a link here to the Nebraska Magellan website. They, again, as Barb mentioned, they maintain a list of credentialed providers who have met sort of those training requirements for CPP and PCIT, and they maintain a list of providers on their website. So this is a link to their website with the two lists for CPP-approved therapists and PCIT-approved therapists.
Okay. So we're available for your typed in questions. We're hearing crickets out there. You didn't need to take the clock out.
No, I guess not.
We've got some active typing out there.
Uh-oh.
So we had little typing icons and now they've kind of disappeared. We'll give it a minute and see if we can see your question.
Charlie, our chat box went away. Oh.
Okay, we're hopeful again.
So it looks like people are typing, but we're not seeing it. I don't know if...
Oh,
Oh,
okay.
thanks, Beth. Hi, Beth.
This is sort of a first round for us. We developed this presentation for the webinar, but anticipate to do it again. So any comments about additional questions it raises or additional things to clarify, whether you can do that on the screen tonight or send them to us via Charlie, we'd really appreciate that because we expect to use this presentation again.
We'd really like to do it with caseworkers and other,
Right.
other people, professionals in the community too. So.
Oh, thank you, Charlie. Sorry about the technology. It's sort of the story of my life.
It's okay. We were prepared for the one video to not work, so it was all good. Thanks, Charlie, for all your help.
It looks like John's typing a comment, so we'll give that a minute. Okay, we see John making some efforts to get a question in. It just kind of keeps disappearing, though. Oh, okay. John, I'm a provider who actively utilizes.
Can everybody see the questions, or do you want us to read it? Okay, so John says, I am a provider who actively utilizes child-parent relationship therapy, CPRT, in my work. It is a research-based intervention approach which sounds similar in terms of goals and approach. Briefly speaking, it addresses attachment and uses play to reach goals. Is either of you familiar with differences between CPRT and CPP or PCIT?
I'll give a big no to that one.
Yeah, I'm not.
Yeah.
I have very briefly heard of CPRT, only because somebody confused PCIT with it and asked me if I did, but I'm not that familiar with it, so no. But I'm intrigued, so I'm gonna look it up. You've intrigued me.
Okay. Well, I think we're going to sign off then. We want to thank you, Ghost audience out there, for hanging in with us, and we appreciate your comments.
Thanks, everybody. Have a good night.